Hello everyone. We will be starting with chapter 5 of textbook illustrated textbook of pediatrics, care of sick child and young person. Features of the care of a sick child and young person are the number of children and young people attending and being admitted to hospital continues to increase. The care of children and their families in hospitals should include their holistic, emotional, spiritual, and social needs. Pain management needs to be considered even in patients too young to describe it. Ethical and consent issues are centered around considering their best interest, and when able to understand the issues, the child or young person should also be involved. Research is vital to provide an evidence base to deliver quality care. Sick children have different requirements of medical care for adults from adults. This is true both in primary care and in hospital. Not only does hospital care need to be child and family centered, but also the holistic care provided needs to include the management of pain, safe prescribing, and good communication. It should be based on sound ethical principles and, whenever possible, on evidence based medicine underpinned by research. If needed, palliative and end of life care should be available. How these apply to pediatric practice is described in this chapter. Primary care: the majority of acute illness in children is mild and transient, for example, upper respiratory tract infection, gastroenteritis, or readily treatable, for example, exacerbation of asthma, and is provided by parents at home as shown in the figure. This is a schematic representation of provision of medical care for sick children in the UK. Most is by family with medical support from primary care. Relatively few need secondary care, and only a very small number require tertiary or national centers. When more seriously ill, for example, a high fever, not feeding, difficulty breathing, lethargy, parents require rapid access to advice or assessment by an experienced clinician. Advice may be provided on the internet or by telephone, for example, NHS Direct. Medical care is initially provided by general practitioners or, in some countries, by primary care pediatricians in conjunction with other healthcare professions. Ready access to secondary care should be available, although an individual general practitioner will care for relatively few children with serious chronic pediatric illness, for example, cystic fibrosis, diabetes mellitus, or disability, for example, cerebral palsy. Each affected child and family are likely to require considerable input from the whole of the primary care team. The medical care of normal children, the Healthy Child program for immunization, screening, and developmental reviews and health promotion are provided within primary care. This diagram shows the schematic representation. First is parents and family, parents, extended family, and friends. Primary care includes telephone, NHS Direct, walk-in centers, GP practices, pharmacies, dentists, opticians. Secondary care: children's emergency departments, hospitals, mental health trusts, specialist retrieval teams, and then tertiary care and national centers. Now, secondary care, emergency and urgent care: almost 5 million children and young people aged 0 to 19 years, 1 in 4 attend an accident and emergency department each year in the United Kingdom. This number continues to increase. The rates of attendance are highest in preschool children, almost 2 million, and are only exceeded by those over 80 years of age. One reason for this is that young children need urgent review if they become significantly ill, often with a high fever or difficulty breathing, as the condition can deteriorate rapidly. Another common research for attendance is injuries. Specially trained staff and special facilities are required for the urgent assessment and management of children and young people attending an accident and emergency department, as listed in box 5.1, which we will discuss Later, children should be kept separate from the often unpleasant environment of adult emergency department. Increasingly dedicated separate emergency departments for children are being created. Now, the hospital admission rates in England, just over 2 million children younger than 15 years of age were admitted in hospital in 2012. This represents 11.4% of the total number of hospital admissions. Almost three quarters of acute admissions are under the care of pediatricians, and the remainder are surgical patients, although pediatrician or pediatric surgeon is also involved in their care while they are in hospital to oversee any medical requirements. Most pediatric admissions are of infants and young children under 5 years of age and are emergencies, whereas surgical admissions peak at 5 years of age, one third which are elective. As shown in the figure, the most common reason for medical admissions are shown in table 5.1, which is the stable services that should be available for children attending an accident and emergency department, environment, staff, and medical care. Environment includes initial clinical assessment occurs within 15 minutes of arrival, separate waiting area, play facilities, child-friendly treatment, and recovery areas. Access for parents to examination, x-rays, and anesthetic rooms. Staff, medical nursing staff trained and experienced in the care and treatment of children and young adults, including mental health. Non-pediatric staff trained in communicating with children and families, effective communication with other health professionals, medical care, resuscitation, and other equipment for children, children given priority for prompt treatment, special priority arrangement for children with serious long-term illnesses, rapid transfer if inpatient admission is needed, if intensive or specialist care required, dedicated transport services available within regional critical care or specialist networks, child protection advice available from experienced pediatrician, procedure and counseling in place following the sudden death of a child. Now, this bullet point, hospital admission of children should be avoided whenever possible. Most medical admissions are infants and young children. Surgical admission occur throughout childhood. The hospital admission rate has continued to rise over the last 20 years. Between 1999 and 2010, there was an increase of 28% in the number of emergency admissions, as shown in this figure, and the effect was most marked in younger children. The reason for this are unclear but probably include lower threshold for admissions, the lack of an instant test to rule out serious illnesses, increasingly risk averse nature of medical practice, which has resulted in an increase in short stay admission less than 24 hours, the repeated admission of children with complex conditions who survive longer, for example, ex-preterm infants, children with cancer or organ failure. Although the number of admission continues to increase, strenuous efforts have been made to reduce the rate and length of hospitalizations, as shown over here. Ambulatory pediatrics has developed to provide hospital care for medical problems outside inpatient pediatric wards. In addition, subspecialty of pediatric emergency medicine has been developed to provide specialists with expertise to provide care for all acutely ill children with an aim of preventing admission whenever possible. Dedicated children's short stay beds within or alongside the emergency departments are increasingly available to allow children to be treated or observed for a number of hours and discharged home directly, avoiding the need for admission to the ward. Daycare surgery has been instituted for many operations, and day units are used for complex investigations and procedures instead of inpatient wards. Home care teams aim to provide care in the child's home and thereby reduce hospital attendance, admission, and length of stay. This may include specialist care, for example, for treating diabetes and asthma, or providing home oxygen therapy, palliative care for terminally ill children, as shown in the figure. Children's hospices provide respite and palliative care for children with life threatening conditions such as malignant and neurodegenerative disorders. Some teams provide hospital at home service for children who are acutely ill in order to avoid hospitalization. Uh, this is a table which shows reasons for emergency admission of children under 15 years of age to hospital system. Respiratory 25%, and injuries and poisoning 17%, gastroenterological 13%, infection 6%, urogenital 3%, neurological 2%, endocrine and metabolic 2%, skin 2%, musculoskeletal 2%, other 28%. These were the system. Now, specific disorders: respiratory infection 20%, asthma 3%, head injury 5%, poisoning 1%, gastroenteritis 5%, viral infection 5%, urinary tract infection 2%, seizures 1%, diabetes mellitus 1%. Now, the summary regarding secondary care for children in the UK: each year, up to half of infants aged under 12 months and one quarter of older children attend emergency departments. 1 in 11 children are referred to the hospital outpatient clinic. 1 in 10 to 15 children are admitted to hospital. 1 in 1,000 children require intensive care. 1 in 10 to 15 newborn babies are admitted to the neonatal unit. Of those, about 2% need intensive care. Children in hospital: children should only be admitted to hospital if effective and safe care cannot be provided at home. Removing young children from the familiar environment to a strange hospital ward is stressful and frightening for the child. Parents and family: ill or injured children may regress in their behavior, acting younger than their actual age. If places a child at risk of nosocomial infections and iatrogenic harm through medical errors, for example, prescribing errors. It also disrupts family routines, not only of the child in hospital, but also of siblings who still need to be looked after at home and transported to and from nursery or school. Putting the family and child at the center of care. Care in hospital should be child centered and family centered, with a holistic approach towards the child and family rather than simply focusing on the medical condition. This requires the child care to be tailored to their physical and emotional maturity and needs, and not having to adapt to standardized ward routines. Parents of infants and young children should be allowed to stay with their child overnight, amazingly, something not allowed in the 1950s, and continue to provide the care and support they would give at home. Parents know best about their child's usual behavior and habits, and due attention must be paid to their worries or comments, including intuition in recognizing cue deterioration in their child. Increasingly, this is recorded as part of the regular observation on children. Good communication is needed between staff and parents to arrive at a mutually agreed plan of responsibilities for looking after the child. This will avoid parents either feeling pressurized to accept responsibilities they are not confident about, or feeling brushed aside and undervalued by staff. For children with chronic conditions, many parents rapidly learn some of the nursing skills, for example, nasogastric tube feeding, if required by their child. Child-oriented environment: children should be cared for within a children's ward, which should be provided for the child's physical and emotional maturity and needs. Adolescents should be with others of their own age and not forced to accept ward arrangements designed for babies or adults. Education and facilities for play should be provided. Information, psychosocial support, detailed information should be provided, given personally and preferably also written and available in appropriate ethnic languages. Staff should be sensitive to the family's individual needs according to your social, educational, cultural, and religious background. Emotional and psychological support should be available, and all staff members should be aware of the effects illnesses and injury can have on children and their families. For elective admissions, children and their families should be offered an advance visit and have details of proposed treatment and management explained at an appropriate level. Skilled staff: Children in hospitals should be cared for by specially trained medical, nursing, and support staff. The care of every child admitted to hospital should be supervised by a pediatrician or pediatrically trained surgeon, as children constitute only a relatively small proportion of the workload in acute surgical specialties. Surgeon anesthetists should treat a sufficient number of children to maintain their skills. Dedicated children's physiotherapists and occupational therapists have specialist skills that are required to optimize the outcomes for children. Play specialists are an essential part of the ward team because they can help children understand the illnesses and its treatment through play. Children with complex needs should have an experienced healthcare professional as a contact person to ensure care is coordinated and investigations or procedures are not duplicated. Multidisciplinary care, coordinating care across boundaries. Successful management of pediatric conditions often relies on a network of multidisciplinary care with all professionals working well together as a coordinated team. If this breakdowns, particularly when dealing with complex issues such as child protection and long term disability, there may be serious consequences for the child, family, and professionals involved. Psychiatrists, the community pediatric team, and social services are important members of the team. Tertiary care networks, number of children requiring tertiary care is relatively small, so it is concentrated in specialist centers. Tertiary care in pediatrics include neonatal and pediatric intensive care and cardiac and oncology centers. They have the advantage of having a wide range of specialists, not only medical and surgical staff, but also nursing and other healthcare professionals and diagnostic and other services. For critically ill neonates and children, specialist retrieval team have been developed to provide initial resuscitation and post resuscitation care at secondary care hospitals and then provide transport to the tertiary center. For some rare and complex disorder, for example, immune deficiency disorders and inborn errors of metabolism and complex treatments, for example, transplantation and craniofacial surgery, national centers have been developed. A disadvantage is that there are often some distance from the child's home and hospital stay may be prolonged. For example, following a bone marrow transplant, accommodation for parents should be provided in this situation in order to minimize the need for the child to travel to tertiary centers. Shared care networks have been established between tertiary centers and local hospitals. For example, child with leukemia might attend tertiary center for the initial diagnostic assessment and treatment and subsequently for specialized treatment and periodic review, but much of the maintenance therapy would be provided by the local hospital together with monitoring of their health and regular blood and other tests performed by a specialist nurse at home. Specialists from the tertiary center may also hold periodic clinic at the shared care center. Such shared care networks rely on excellent communication between all the health professionals involved. Now, discharged from hospitals, children should be discharged from hospital as soon as clinically and socially appropriate. Although there is increasing pressure to reduce the length of hospital stay to a minimum, this must not allow discharging planning to be neglected. Before discharge from hospital, parents and children should be informed the reason for admission and any implication for the future. Details of medication and other treatment, any clinical feature that should prompt them to seek medical advice, and how this should be obtained. Safety netting. Problems or questions likely to be asked by other family members or in the community. These should be anticipated by the doctor and discussed. For instance, what should the nursery or school babysitters or friends need to know? What about sports, etc.? In addition, consider suitability of home circumstances, social support that may need to be arranged, especially in relation to child protection. What medical information should be added to the child's personal child health record? Which profession should be informed about the admission and what information it is relevant for them to receive? This must be done before or any time of discharge. The aim is to provide a seamless service of care, treatment, and support with the family, ensure that all the professionals are fully informed. As shown in this figure, some of the professionals who may need to be informed about the mission discharge of a child admitted to the hospital. All these professionals are shown in the figure, including general practitioners, health visitor, community pediatrics services, consultant in other specialty, child development team, dietitian, tertiary center, social services, pediatric home care team, physiotherapist, occupational therapist, speech and language therapist, child psychiatrist, psychologist, and school. Now, little summary: children in hospital should be provided with family centered care, holistic approach to family, parent of young children, able to stay and provide parental care, child oriented environment appropriate for child's age, together with education and play facilities, information and psychological, psychosocial support, verbal and written information for both parents and child, the opportunity for children and families to express their views and fears and be listened to, skills staff specially trained to care for children, multidisciplinary care, access to tertiary care with shared care arrangements with local hospital and primary care. Pain in children. Pain is a major concern for children and parents across all specialities. Whilst it is necessary to ignore or underestimate pain in children, it should highly be anticipated and prevented and always taken seriously. Acute pain, this may be caused by musculoskeletal tissue or organ damage, for example, trauma, burns, or fractures. Inflammatory process from local infection, for example, skin, respiratory or urinary tract, joint, bone, peritonitis, or meningitis, obstruction, for example, intussusception, renal colic, hydrocephalus, vaso-occlusive disease, for example, sickle cell crisis, medical intervention, i.e., investigations, for example, venipuncture or lumbar puncture procedures, for example, change of wound dressings, surgery. Chronic pain in children. Chronic severe pain sometimes occurs as a result of disease such as malignant disease or juvenile idiopathic arthritis or complex regional pain syndromes. Intermittent pain of mild or moderate severity, for example, headache or recurrent abdominal pain is more common but can be very distressing for children and their families. Pain management should be approached by recognizing, responding, and reassessing. Recognizing pain. Older children can describe the nature and severity of the pain they are experiencing. In younger children and those with developmental delay, assessing pain is most difficult. Observation and parental impression are commonly used, and a number of self assessment tools have been designed for children over 3 years of age. As shown in this picture, observation is a key component of pain assessment in children. The child who is extremely quiet, especially after trauma, may be in significant discomfort. Responding to pain, the approaches to pain management are listed in the box we will show in a bit. This should allow pain to be prevented or keep to the minimum. Age appropriate explanation should be given when possible, and approach should be reassuring. However, it is imperative not to lie to children, otherwise, they will lose trust in what they are told in the future. Distraction techniques such as blowing bubbles, telling stories, holding family toys, or playing computer games, as well as the involvement of trained play specialists, can be highly successful in ameliorating pain in children. Some children develop particular preferences for a particular venipuncture site or distraction technique, and this should be accommodated as far as possible. In the box shown approaches to pain management, information and psychosocial support, psychological by the parent, doctor, nurse, or play specialist, behavioral, distraction, hypnosis, medical, which includes local anesthetic cream, local anesthetic infiltration, nerve blocks, warmth or cold, physiotherapy, transcutaneous electrical nerve stimulation, analgesic, mild, moderate, paracetamol, non-steroidal inflammatory drugs, NSAIDs, strong morphine, sedatives and anesthetic agents, ketamine, midazolam, nitrous oxide, general anesthetics, anti-epileptic and antidepressant drugs for neuropathic pain. Consider the route for analgesics: oral if possible, otherwise intravenous, sub-Q, or rectal. Intranasal administration is becoming increasingly popular in children as it is well tolerated. For minor medical procedures, for example, venipuncture, inserting an intravenous cannula, pain can be alleviated by explanation and the use of a topical anesthetic. Additional and appropriate additional and appropriate use of inhalational agents such as nitrous oxide or the adjunctive use of mild sedatives, midazolam, hypnotics, ketamine, alongside pain relief can be helpful for more painful procedures such as suturing a wound. For more invasive procedure, for example, bronchoscopy and general anesthetic should be given. Post-operative pain can be markedly reduced by local infiltration of the wound, nerve blocks, or post-operative analgesics. Severe pain, especially from fractures and surgical procedures, should be adequately treated with opioid analgesics. In the past, there was reluctance to use morphine in children for fear of depressing breathing, but this should not occur when morphine is given in appropriate dosage under nursing supervision to children with a normal respiratory drive. Intravenous morphine can be given using a patient-controlled delivery system in older children or a nurse-controlled system in young children. Acutely intranasal opiate agents, for example, diamorphine, can be given, which are highly effective as they are observed rapidly from child's nasal mucosa. Recessing pain. This is a vital part of the pain management in children, although children often have parents and carers as advocates. The child's pain scores should be regularly reviewed. Now the bullet point: pain should be anticipated and prevented as well as being treated promptly. Prescribing medicines to children, there are marked differences in the absorption, biology, clearance, and distribution, which is ABCD of drugs between children and adults. Many doses of medicines have to be calculated using either weight, age, or surface area. This added complexity means that children are at risk of prescribing errors. Indeed, a recent survey across 5 London hospitals found an error in 13% of all prescriptions for children. Young children find it difficult to take tablets, and thus a liquid formulation is required. Most are glucose free. Persuading children to take medicine is often a problem, especially if the preparation has an unpleasant taste. Experience and imagination help to overcome their reluctance. Adherence compliance is improved when medicines are only required once or twice a day and regimens are kept simple. Basic understanding of pharmacology of the commonly encountered medicine pediatrics is helpful, i.e., however it is absorbed in different age groups. How it works is biology, how it is cleared, and how quickly and how it is distributed. All these will affect dosing. Sometimes only limited data are available. An up-to-date reference formulary, for example, the British National Formulary for Children, should be consulted for all prescriptions. Now, the absorption. In neonates and infants, oral formulations of drugs are given as liquids. However, the intake cannot guarantee, and absorption is unpredictable as it is affected by gastric emptying, acidity, gut motility, and effect of milk in the stomach. And acutely in neonates and infants, drugs are therefore given intravenously to ensure reliable and adequate blood and tissue concentration. Intramuscular injections should be avoided if at all possible, as there is little muscle bulk available for injection. Absorption is variable and they are painful. Rectal administration can be used for some drugs, although absorption is more reliable than oral administration. This route is not popular in the UK. Significant systemic absorption can occur across the skin, particularly in preterm infants. This is a potential cause of toxicity. For example, alcohol and iodine absorption from cleansing solutions applied to the skin for procedure. Biology. The precise mechanism of action can vary considerably between adults and children and within children of different ages for the same drug. For instance, paracetamol is metabolized by different and slow mechanism in neonates compared with older children and adults. This increases risk of overdose. Some medicines should be avoided in children as they may cause idiosyncratic adverse reactions. For example, aspirin should be avoided in children less than 16 years of age as it is associated with a risk of Reye syndrome causing encephalopathy and liver failure. Clearance in neonates, drug biotransformation is reduced as microsomal enzymes in the liver are immature. This leads to a prolonged half-life of drugs metabolized in liver, for example, theophylline. Renal excretion reduced by the low glomerular filtration rate, which increases the half-life of some drugs, for example, gentamicin, making the plasma drug concentration is necessary under these circumstances. Distribution: water comprises a larger percentage of the body in the neonate, 80%, than in older children and adults, 55%. Drugs that distribute within extracellular fluid will require a larger dose relative to body weight in infants than in adults. And extracellular fluid correlates with body surface area. This is used when accurate drug dosage is required. For example, cytotoxic agent for drugs with a high margin of safety. Drug dosages are expressed per kilogram body weight or based on age, with the assumption that the child is of average size. Weight-based dosages should not simply be extrapolated to older children, as the dosages will be excessively large. In the first few months of life, plasma protein concentration is low, and some drugs may be partially unbound and remain pharmacologically active. In jaundice babies, for example, bilirubin may compete with some drugs, for example, sulfonamides for albumin binding sites, making such drugs unsuitable for use in this situation. Summary: regarding medicines for children, oral formulations need to be given as liquids. In infants and young children, medicine is usually prescribed per kilogram body weight, but check the maximum dose. Intramuscular drugs should be avoided if at all possible. Intravenous drug dosages can easily be miscalculated as they vary widely in children because of their different size, and drugs often need to be diluted. All dosages and dilutions must be checked independently by two trained members of staff to improve compliance. Use formulations requiring the least number of time to be taken per day. Always check drug dosage in the British National Formulary of for children. Communicating serious problems: doctors often face the difficult task of imparting serious issues to parents and children. In pediatric practice, it may be because there is a serious congenital abnormality at birth, for example, chromosomal disorder, the diagnosis of a disabling condition, for example, cerebral palsy, neurodegenerative disorders, gross intracranial abnormalities seen at ultrasound in a preterm infant, serious illness, for example, meningitis or malignant disease, or an accident, for example, head injury, sudden death of a child, for example, sudden infant death syndrome. In addition, families often perceive less serious problems as being very serious, and many of the principles described in the following section will be applicable. Initial interview: the manner in which the initial interview is conducted is very important, may have a profound influence on the parent's ability to cope with the problem and their subsequent relationship with health professionals. Parents often continue to recall and recount for many years details of the initial interview when they were informed that their child had a serious problem. Parents of children with life threatening illnesses have said that what they valued most was open, sympathetic, direct, and uninterrupted discussion in private that allowed sufficient time for doctors to repeat and clarify information and for them to ask questions. Palliative and end of life care. Palliative care should begin from the time of diagnosis of a life limiting illness and may continue for many years. It includes pain and symptoms management for the child, psychosocial support for the child and family, attention to practical needs, and spiritual care. It may also include respite care and bereavement support for the family after the child has died. End of life care is used specifically to describe the period of care when death is imminent. Care plan: a care plan should be developed for children with a life threatening illness. It needs to address symptom care and medical and emotional support, clarify the roles of the clinical teams involved, and make management plans for potential crisis. It needs regular review as the illness evolves. Place of care: if the child is in hospital, there should be a private area for the child and family. If care is provided at home, it is essential that the family has support and information about whom to contact for routine and emergency problems, including medications, and what to expect when the child dies and afterwards. The needs of the child are paramount, but all family members must be considered. Many will not have encountered death before. Some families will have specific religious needs. Care after death, families should be involved in the child's end of life care and care after death according to their wishes. Their individual cultural and religious beliefs and rituals should be accommodated whenever possible. For example, some families may wish to take their child home from the hospital or hospice, and some cultures have specific requirements about burial and its timings. Families are encouraged to hold the child before and afterwards if they wish to do so. The family should be provided with information about registering a death and making funeral arrangements. Some families create memory boxes with mementos from the child. All health professionals involved should be informed when the child has died. Grief following death is normal and intense and may continue to affect families for years. The family should be informed about support that is available. Caring for staff, many staff will be distressed as they will have known the child for a long time. If the death was sudden and unexpected, there may be feelings of failure. Open discussion is often helpful by clarifying the events and allowing staff to express their concern. The box shown how parents wish to be told about a serious problem, setting in private, uninterrupted, unhurried, both parents or friend or relative present if possible, senior doctor, nurse, or social worker present. Establish contact, find out what the family knows or suspects, respects the family's vulnerability, use the child's name, do not avoid looking at them, be direct, open, sympathetic, provide information, flexibility is essential, do not protect from bad news but pace giving it. Name the illness or problem, describe symptoms relevant to child's condition, discuss etiology. Parents will usually want to know. Anticipate and answer questions. Do not avoid difficult issues because parents have not thought to ask. Explain long term prognosis if the child is likely to die. Listen to concerns about time, place, and nature of death. Outline the support treatment available. At-risk feeling, be prepared to tolerate reactions of shock, especially anger or weeping. Acknowledge uncertainty. How is it likely to affect the family? What and how to tell other children, relatives, and friends. Concluding the interview, elicit what parents have understood, clarify, repeat, acknowledge that it may be difficult for parents to absorb all the information. Mention sources of support if possible, give parents a contact telephone number, give address of self-help group, follow up. Offer early follow up, suggest to families that they write down questions in preparation for the next appointment, ensure adequate communication of content of interview to other members of staff, general practitioner, and health visitor. Other professionals, for example, a referring pediatrician. Ethics situations arise in pediatric practice in which the course of action that should be followed is unclear. Knowledge of the ethical theories and principles that underpin medical practice may be helpful in understanding the issues involved. It is important to justify the decision to investigate or treat in accordance with these principles and in language that is clear to all concerned. Definition of principles of medical ethics. Non-maleficence, do no harm, psychological and or physical. Beneficence, positive obligation to do good. These two principles have been part of medical ethics since the Hippocratic Oath. Justice, fairness for all, equity and equality of care, respect for autonomy, respect for individuals' rights to make informed and thought out decisions for themselves in accordance with their capabilities, truth telling and confidentiality, important aspects of autonomy that support trust, essential in the doctor patient relationship, duty, the moral obligation to act irrespective of the consequences in accordance with moral laws, which are universal, apply equally to all, and which respect persons as autonomous beings. Utility, the obligation to do the greatest good for the greatest number. Rights, justifiable moral claims, for example, the right to life, respect, and education, which impose moral obligations upon others. Application of ethical principles to pediatrics, non maleficence. Children are more vulnerable to harm. This includes the suffering from fear of procedures which they may be too young to express verbally. Doctors may do harm from lack of skill or knowledge, especially if they do not treat child frequently. Beneficence, the child entrusted is paramount. In the UK, this is This is enshrined in the Children Act 1989, the United Nations Convention on the Rights of the Children. This may sometimes conflict with parental autonomy, such as emergency treatment of a child where the parent is not immediately available, or when details are given to social workers in suspected child abuse. Justice. This involves ensuring a comprehensive child health service, including the prevention of illness and equal access to healthcare, even when poverty, language barriers, and parental disability are present. Autonomy. Children have restricted but developing rights in law. Parents are trusted to make decisions on the child's behalf because they will usually act in the child's best interest, but there may be circumstances, for example, child abuse, in which this is not the case. Truth telling, it is more difficult with children than adults to be sure that they understand what is happening to them. For example, it's easy to reassure children falsely that procedure will not hurt. When they find this is untrue, trust will be lost for further occasions. Consent. Valid consent is required for all medical interventions other than emergencies or when urgent intervention is necessary to prevent serious risk of present or future harm. It provides ethical and legal authority for action, which would otherwise be a common assault or interfere with the right of individuals to decide what should be done to them. Autonomous choice. To be valid, consent must be sufficiently informed and freely given by a person who is competent to do so. Clinicians have a duty to provide sufficient information to enable a reasonable person to make the decision and must answer all questions honestly. Information has to be given in language that is unclear and understandable. In UK law, the legal age of consent to medical treatment is 16 years. The right of children below this age to give consent depends on their competence rather than their age. They may consent to medical examination treatment provided they can demonstrate that they have the maturity and judgment to understand and appraise the nature and implication of the proposed treatment, including the risks and alternative courses of action. This case was tested in law, Gillick versus West Norfolk Health Authority, and resulted in the Fraser Guidelines. They were originally devised to provide advice for healthcare professionals in determining when it would be appropriate to give oral contraceptive agents to girls without their parents' knowledge. In order to be Fraser competent, the healthcare professional has to ensure that the girl, although under the age of 18, understands his or her advice, could not be persuaded to inform her parents, or for them to be informed that she is very likely to continue having sex with or without consideration of physical and mental health, or both, is likely to suffer unless she receives contraception and her best interests are served by receiving contraception. The principles of this case are now applied in other situations. When a child lacks the maturity and judgment to give consent, this capacity is given to a person having parental responsibilities, usually a natural parent, or to a court. In practice, problems occur only when there is disagreement between the child and the parents and clinicians over treatment. Despite including children's view in consent, legal judgment have not supported children who refuse treatment which parents and clinicians feel to be in their best interest, especially if its purpose is to save life or prevent serious harm. For example, heart transplantation for acute cardiomyopathy in an intelligent 15-year-old patient, where disputes cannot be resolved by negotiation and mediation, or there is doubt over the legality of what is proposed, legal advice should be sought. Whatever the outcome, children should have their views heard and be given reasons as to why they are being overridden. Confidentiality. Children are owed the same duty of confidentiality as adults, irrespective of their legal capacity. In general, personal information about them should not be shared without their consent or agreement unless it is necessary for their health or to protect them from serious harm. For example, in actual or suspected child abuse. Best interest. It is a general ethical and legal maxim that the best interests of the child are paramount. Doctors therefore have a duty to save life, restore health, and prevent disease by treatments that confer maximum benefit and minimal harm, and which respect the autonomy of the child as far as possible. Parents have the ethical and legal duty to make decisions on behalf of their child, provided that they act in their best interest. Disagreement can occur between parents and health professionals over the best interest of the child, especially when the withholding or withdrawing of life sustaining treatments is involved. Under these circumstances, an independent opinion may be helpful, but sometimes legal intervention is required. Courts have generally been supportive of the position that in some circumstances the burden of the child of providing life sustaining treatment overweighs its benefits. Case histories 5.1 and 5.2 demonstrate some of the ethical problems encountered in pediatrics, which will be discussed below. The ethics of research in pediatrics. Research involving children is important in promoting child's health and well-being and when providing evidence base for practice. However, the number of trials and other forms of research is much less than in adult medicine. This paucity of research is highly detrimental to improving care, and great efforts is being made to increase research conducted in pediatrics. A particular example is our knowledge about drug therapy in children. Although they differ from adults in their anatomy, physiology, disease pattern, and responses to therapy, many drugs are not licensed for use in children because they have not been specifically tested in them. Pharmaceutical companies are now being encouraged or forced by legislation to test their medication in children where a child suffers from a particular disease, for example, acute lymphoblastic leukemia. Randomized controlled trials may be used to compare treatment regimens. The ethical justification for such trials is that there is no good reason to believe that one of the treatments would be better than the other therapeutic equipoise, and that the standard treatment used for comparative purposes is the best currently available. The situation is different when investigation, for example, blood test, X-ray, or intervention is proposed for healthy children as part of the control group in a trial or for the purpose of establish a normal range. Both can be ethically justified provided that the procedure in question carries no more risk than generally encountered and accepted in everyday life. Whatever the nature of the research, a number of criteria must be met. Appropriate research should be first carried out in adults or older children. The project should have a sound scientific basis and be well designed. The researchers should be competent to carry it out in the time specified. Sufficient information should be given in a form comprehensible to the child and family to enable them to give valid consent to participation, for example, by provision of information sheets in an appropriate form and language or by the use of independent translators. Parents must have the option to withdraw their child from the research at any stage without prejudice. The project must be reviewed and approved by an independent scientific and ethical process, research ethics committee. This is an increasing requirement for not only group of parents and carers to be involved in considering research studies, but to also get input for groups of children and young people themselves. Now, the summary: ethics in pediatrics. Both clinicians and parents aim to do what is in the child's best interest. Conflicting views can usually be resolved by good communication. If not resolved, help may be sought from further wider communication or a second truly independent opinion, or sometimes from hospital ethical committees, or may go to court. In older children who understand the issues and have strong views as to what should or should not be done to them, there is increasing ethical and legal support for them to exercise as much as autonomy as they are capable of. Now, the case history 5.2 and 5.1. First, the case history 5.1. Diabetes mellitus. Jack, aged 5 years, has a high blood sugar and is showing classical signs of diabetes. Jack hates needles and make it clear that he rejects any sorts of injection. No, I don't want an injection. Go away is the message loud and clear when you try to take blood to confirm the diagnosis. Yet, with the full and anxious approval of his parents, you go ahead and do these things anyway. If Jack was 25 years old and made it clear that he refused your intervention while you would strongly urge him to give permission and explain that he was in real danger of dying as a result of such refusal, you would not presumably treat him against his will, even if his mother and father still urged you to do so. In contrast to traditional adult medical ethics, in pediatrics, autonomy of the patient either is not present at all, as in babies and young infants, as is often not sufficiently developed to be respected if the child's decision conflicts with what other people consider to be appropriate in their child's best interest. The decision about the child's medical care are generally entrusted to the parents. Why the parents? They are given the privilege and responsibility of making decisions on behalf of their children, largely because they are most likely to protect and promote the interest of their children. The normal assumption in pediatric practice is that doctors should work closely with parents and give advice that parents may or may not accept. Wherever possible, mutually trusting and respectful working relationships should be developed and maintained, both because it will be in the best interest of the child and because it will tend to lead to far better experiences of medical care for all involved. Also, consider whether your decision would have been the same about performing an extra venipuncture for a special blood test for an ethically approved research project. Case history true. Case history 5.2, acute lymphatic leukemia, truth telling and stopping treatment. Millie, aged 10 years, has acute lymphoblastic leukemia, which was diagnosed 4 years ago. She has relapsed with early involvement of the central nervous system. She is well known to the staff of our local children's ward as she has had 4 relapses of leukemia and a previous bone marrow transplant. It is the opinion of a pediatrician consultant that no further medical treatment is likely to be curative. Millie asked one of the junior pediatric doctors why her parents have been so upset following a recent discussion with the consultant at which she had not been present. The parents have made it very clear to all the staff they did not want their children to be informed of the poor prognosis, nor would they tell her why she was not having further chemotherapy. The parents have heard of a new drug that is claimed in some reports on the internet to help such children. However, it is very expensive. There is evidence that it does not cross the blood-brain barrier, and the doctors consider it highly unlikely to be of benefit. The parents insist on a trial of the drug. Ethical issues to consider are autonomy. The parents claim the right to control the information reaching their child on the grounds that it is in her best interest as judged by them. Two, telling the staff feel that it would be wrong to reassure her falsely. Non-maleficent, the parents wish to avoid the shock of the news and the loss of hope in their daughter. Beneficence, the staff wish to support the child effectively, which would be difficult if she were to be isolated by ignorance of what is upsetting her family and carers. Justice, should scarce resources be used on this new drug because her parents are desperate, should Millie be given a drug which, in this specialist opinion, will not benefit her best interest? What are Millie's best interests and who should decide them? What weight should be given to Millie's own views based on her experience of an illness? In such situation, further discussion between the parents and staff whom they trust is usually the key to resolving the situation. The parents will need to understand the mutual benefits of adopting as open a pattern of communication as possible. They may be helped by a member of staff being present or helping them talk or listen to the child, who will usually understand more than the parents suspect. Parents almost always wish to do the best for their child. Detailed explanation is likely to help them see that the child's best interest may not to seek further cure but to accept a change of focus towards palliative care. A second opinion from an independent specialist may be helpful, as may a specific ethical review. If despite all efforts to reach agreement the parents reject the doctor's advice, it is fairest to let a court of law decide whether or not to accept the parents' demands. Evidence-based pediatrics, clinicians have always sought to make decisions in the best interest of their parents. However, such decisions have often been made intuitively, given as clinical opinion, which is difficult to generalize, scrutinize, or challenge. Evidence-based practice provides a systematic approach to enable clinicians to use the best available evidence, usually from research, to help them solve their clinical problems. The difference between this approach and old-style clinical practice is that clinicians need to know how to turn their clinical problems into questions that can be answered by the research literature, to search the literature efficiently, and to analyze evidence using epidemiology and biostatistical rules shown in the figure. Sometimes the best available evidence will be a high quality systematic review of randomized controlled trials which are directly applicable to a particular patient. For other questions, lack of more valid studies may mean that the decision has to be made on previous experience with a small number of similar patients. The important fact is that for any decision, clinicians know the strength of the evidence and therefore the degree of uncertainty. As this approach requires clinicians to be explicit about the evidence they use, others involved in the decision, patients, managers, and other clinicians can debate and judge the evidence for themselves. Why practice evidence-based pediatrics? There are many examples from the past where, though lack of evidence, clinicians have harmed children. For example, blindness for retinopathy and prematurity. In the 1950s, following anecdotal reports, many neonatal units started nursing all premature infants in additional ambient oxygen, irrespective of need. This reduced mortality, but as no properly conducted trials were performed of this new therapy, it took several years for it to realize it was also responsible for many thousands of babies becoming blind from retinopathy of prematurity. Advice that babies should sleep lying on their front prone, with which increases the risk of sudden infant death syndrome. Medical advice given during the 1970s and 1980s to put the baby to sleep prone appears to have been based on physiological studies in preterm babies which showed better oxygenation when nursed prone. Furthermore, autopsies on some infants who died of SIDA showed milk in the trachea, which was assumed to have been aspirated, and this was thought to be more likely if they were lying on their back. However, an accumulation of more valid evidence from cohort and case control studies showed that placing them term infants prone was associated with an increased risk of SIDS. Now the figure showing a clinical problem. Application of evidence-based medicine to clinical problem. First clinical problem, frame questions. What evidence is needed to reach your decision? Clinical problems are often complex, and the different elements, etiology, diagnosis, therapy, prognosis, need to be tackled as separate questions. Most clinical questions can be structured into these three components: patient population, population similar to your patient; intervention, for example, giving antibiotics compared with not giving antibiotics; clinical outcome, the most important outcome, good or bad; search for the evidence, search the research literature, use search filters for efficiency. For randomized clinical trials and systematic reviews of interventions, go to Cochrane library. If there is nothing which addresses your question, or if your question is about prognosis or diagnosis, you need to use an online database such as Medline. Appraise the evidence, appraise the validity, closeness to the truth, and usefulness, relevance to your patient of the evidence. In intervention studies, there's a hierarchy of validity: a systematic view of randomized controlled trials, RCTs, individual RCTs, cohort studies, case control studies, case reports of anecdotal experience of respective authorities. If your question is about a diagnostic test or observation, you need a study that has made an independent blind comparison with an adequate reference standard based on patients with a similar spectrum of disease to your patient. If your question is about prognosis, you need a study that follows a group of patients similar to your patient over an adequate period to see what happens to them. Make a decision, incorporate the evidence into clinical or policy decisions. This depend on judgments about the validity and relevance of the evidence, the probability of the different outcomes, and the values assigned to them by the patient, clinician, and wider society. They are also heavily influenced by what is feasible within the organization. We will often agree on the validity of the evidence and the probability of different outcomes, but decision may differ because the people involved hold different values. Evaluate your performance, ensure the evidence-based decisions are translated into practice, and measure the wider effects of implementation on healthcare. This may involve audit. Example of the evidence-based practice in solving clinical problem. Should you treat a 3-year-old boy with otitis media with antibiotics? Frame question. Population, children with acute otitis media. Intervention, antibiotic compared with none. Outcomes, pain, hearing loss, adverse stress effects, other complications. Search for the evidence. Cochrane library shows 47 meta-analysis, one corresponding best to this child. Next is appraise evidence, reduce risk 0.5, 1 risk ratios, and 1.5. Pain at 24 hours, pain at 2 to 3 days, pain at 4 to 7 days, perforation, vomiting, diarrhea, or rash, deafness at 3 months. Antibiotics do not affect pain at 24 hours but reduce pain at 2 to 3 or 4 to 7 days. They reduce the number of perforations of the eardrum but not of hearing loss. Antibiotics had side effects of diarrhea, vomiting, and rash. However, rare complication effects and mastocytitis was not assessed as sample size was too small. Risk of antibiotics and cost were not evaluated. The number needed to treat for pain reduction was 20 at 2 to 3 days and 16 at 4 to 7 days. However, antibiotics should be prescribed for children under 2 years of age with bilateral otitis media who are a different study population. Make a decision. You explain to the parents that antibiotics would reduce the risk of pain lasting for more than 24 hours, but you would need to treat between 16 or 20 children for one to benefit. Would cause minor side effects such as vomiting and diarrhea in 1 in 14 children. Decision on whether to treat or not depends upon the parents' values about pain and adverse side effects. One approach would be to provide the information and a prescription for antibiotics, but advise the parents to wait 2 to 3 days and only give antibiotics if the child is still experiencing pain. Evidence-based medicines allows clinicians to be explicit about the probability and risk of important outcomes. For example, in discussing with parents the prognosis of a child who has had a febrile seizure, the clinician can state that the risk of developing epilepsy is 1 in 100 instead of using vague terms such as he or she is unlikely to develop epilepsy. Explicit analysis of evidence has also become more important with the increasing delivery of healthcare by teams rather than individuals. Each team member needs to understand the rationale of decisions and the probability of different outcomes in order to contribute towards clinical decisions and to provide consistent information to patients and parents. To what extent is pediatric practice based on sound evidence? There are two pediatric specialties in which there is a considerable body of reliable, high quality evidence underpinning clinical practice, namely pediatric oncology and to a lesser extent neonatology. Management protocols of virtually all children with cancer are part of a multi-center trial designed to identify which treatment gives the best possible results. The trial are national or increasingly international and include short-term and long-term follow-up. Examples of a range of evidence available in pediatrician are given in the box shown, which we'll discuss later. In general, the evidence base for pediatric is poorer than in adult medicine. Reasons for this is the relatively small number of children with significant illness require investigation and treatment. To overcome this, multi-center trials are required, which are more difficult to organize and expensive. Consent is required on the child's behalf. There has been concern that some parents who find it difficult to consent to treatment that could turn out to be inferior to the standard treatment or have previously unknown side effects and that they had agreed to this. Consent is often required during a time of parental distress, for example, after the birth of preterm infants or after the acute onset of a serious illness. As children cannot give consent themselves, it may not be possible to justify performing additional investigations or other tests, especially if they are painful or not of direct benefit to the child. There is less of a culture of research and of conducting randomized controlled trials in particular. In pediatrics, compared with adult medicine, for evidence-based practice to become more widespread, clinicians must recognize the need to ask questions, particularly about procedure interventions, which are common practice. However, evidence-based medicine is not cookbook medicine. Incontrovertible evidence is rare, and clinical decisions are complex, which is why clinical care is provided by skilled and experienced clinicians. Evidence-based healthcare cannot change this, but is an essential tool to help clinicians make rational informed decisions together with their patient. In addition, evidence-based pediatrics provides a way for clinicians to articulate their priorities for research and thereby set research agendas that are relevant to service needs. Examples of the range of evidence available in pediatrics: number one, clear evidence of benefit, therapeutic hypothermia for newborn infants with hypoxic ischemia encephalopathy, meta-analysis of modern cooling before 6 hours of age for 72 hours shows reduced death or major neurodisability at 18 months of age, with 7 babies needed to be treated for benefit. There is also improved survival with normal neurological function On the basis of animal studies, several multi-center prospective randomized studies of term infants with perinatal asphyxia of intensive care with or without cooling were conducted. Infants had to be identified, assessed, transferred to a treatment center, and treatment started within 6 hours of birth. Consent had to be obtained rapidly from parents shortly after being informed that their baby was dangerously ill. They had to understand the randomization meant their baby may not receive the new treatment and the new treatment may have unknown side effects. It was only when the results of several trials were amalgamated the significant improvement was identified. This demonstrates some of the difficulties that have to be overcome when conducting trials of children, but that is often possible to overcome them. Cooling for moderate or severe perinatal asphyxia has become standard practice in the UK and many countries. Number two, clear evidence but need to balance benefits and harms. Antibiotic treatment for children with otitis media as shown in the figure. There's a balance of risk and benefits. No clear. Number three is no clear evidence. Migraine in children. Although there is good evidence for the use of simple analgesic agent prophylactic treatment of migraine, beta blockers of Pizotifen is poor. This causes a dilemma when choosing the best prophylaxis for a child. Now, the summary evidence based decision requires clinical problems to be framed into questions to search the literature and then appraise the evidence in order to make a decision. Is less well developed than in adult medicine, should be adopted whenever possible. However, clinical decisions are complex and the evidence base usually informs rather than determines clinical decision making. This is the end of the chapter 5. Thank you very much.